Mohammed, can you hear me?
Yes, doctor, you can make your slides full screen and you can start, please. Thank you.
Okay.
Dr. Garner, excuse me, your view is on sideways. Please arrange your view. Yeah, your camera view is still on sideways.
I think I have some issue with the camera, so I can just join you by audio. So, Bismillah ar-Rahman ar-Rahim. Good evening, everyone, and welcome to the challenging cases in oncology mini symposium. This meeting is meant to be short and refreshing, especially during the month of Ramadan. I would like to welcome you all on behalf of the organizing committee, including our co-director, Dr. Ashwag Al-Alayan. And we are aiming in this meeting to present some of the latest advances in the management of variant type of cancer and to discuss the role of MDT teams in the disease management and to help in learning difficult cases. I would like to thank our organizing committee for their help and support, and to extend my thank in advance to our faculty and moderator who will join us over the next 2 days. So the meeting is divided into 2 days. It will be 1 hour and a half. Today, we are gonna have breast cancer cases, sarcoma cases, and genetic case. And tomorrow we have GE gastroesophageal case, hepatocellular, and colorectal cancer case. Without any further ado, I would like to invite Dr. Amin Tijani, who is a consultant medical oncologist at King Abdulaziz Medical City, to join me in moderating the first day cases and to introduce the first speaker. Please, Dr. Amin.
Thank you very much, Dr. Mohammed, for the introduction. It is my pleasure now to start with the breast cancer case. This will be presented by Dr. Nafis Abdul Hafiz. She is a consultant medical oncology, Department of Oncology at King Abdulaziz Medical City in Riyadh. Dr. Nafisa main interest in breast cancer and in thoracic malignancy. So today she will share with us a case of breast cancer. Please, Dr. Nafisa, the floor is yours.
Thank you, Dr. Amin. Thank you for the kind introduction. Thank you, Dr. Mohammed and Dr. Ashwag, Scientific Committee and the Organizing Committee for giving me the chance to present this case. So can you hear me well? Hello?
Yes, clear. Go ahead.
Okay. So I'm going to talk about 51 years. She only underwent spinal surgery in 2007, but no other comorbidities or diseases. She's having very good performance status of 1. Actually, she had been treated somewhere else before we saw her. She had been diagnosed with a case of breast cancer . She's not known to have family history of breast or ovarian cancer. And that time she was treated with neoadjuvant chemotherapy followed by modified radical mastectomy and radiation therapy. Staging was, the final staging was T2 and 2M0. Then she had 5 years of tamoxifen. So she remained disease-free after like 1 year after completion of tamoxifen. Then suddenly she developed generalized convulsions like few months from completion of adjuvant hormonal therapy. She presented to the ER at her local hospital complaining of generalized, she was brought by the family because of generalized convulsions. She underwent complete staging workup, and the first thing that had been done for her was a CT brain, and it showed lesion at left parieto-occipital lobe. Abdominal CT and chest CT and bone scan all were negative for metastatic disease. So at that time, she had been seen by neurosurgery, and the plan was to go for surgical resection of that lesion since it was one disease only. So she had the surgery done, and the pathology came as, again, infiltrating ductal carcinoma grade 2, ER positive and HER2 negative. Ki-67 was very low, it was 5%. She received after that whole brain radiation. At that time, all her blood tests, including CA15-3, were normal, and she was started on LHRH plus letrozole, calcium, and vitamin D. This was in the beginning of 2016. For us, we saw her for the first time in April 2017. Again, she presented to our ER complaining at this time of severe back pain, lower limbs weakness, and it was mainly pain rather than weakness, and there was difficulty in walking because of the pain. Clinical performance was 2. The rest of clinical examination were essentially normal, including CNS examination. Blood tests were normal, and she underwent complete staging workup. This is her spinal MRI. This is like thoracic and lumbar spine MRI in April 2017. We can see that there are multiple levels of bone involvement with even pathological fractures. So as I mentioned, extensive spinal metastasis. There was compression at the level of coda equina. It was at L3. There was pathological fracture at T4 and T5, but there was no spinal cord compression. So if we look at the bone scan, there was extensive metastasis, including skull, multiple levels of the spine, pelvis, both iliac bones, femur, and humerus. So CT abdomen and pelvis, as well as the CT chest, were all negative for metastatic disease. And brain MRI showed stable lesion. It was not, there was no lesion. It was like post radiation changes at the site of the surgical bed. So since we don't have pathology for her, she brought the slide from her local hospital, but she underwent a new biopsy in our hospital. The biopsy was taken from L3 vertebra. It was bone biopsy, and it showed metastatic mammary carcinoma, ER positive, PR negative, and HER2 was also negative. So almost the same, the pathology like the initial one and the one at the time of brain metastasis. So she had been seen by, the case was discussed in the tumor board. Neurosurgery had been called, and according to them, there was no need for intervention since the spinal cord was maintained. There was mild stenosis at the level of the coda equina, but there was no neurological symptoms. So neurosurgery suggested no surgical intervention. So we asked our colleague in radiation oncology to see the patient. So they saw her, assessed her, and they decided to go for radiation therapy. She received actually 30 gray in 10 fractions, and this was completed in May 2017. Also, we got the chance to send her for dental clearance before starting denosumab. So June 2017, she stayed for a good time in the hospital because of the pain. She completed her radiation half of the radiation course at the hospital. So it took a good time as an inpatient, and then she had been discharged, seen in the clinic, and in June 17, she was started on second-line hormonal therapy. So remember, her first line in the metastatic setting was letrozole, and the second line was fulvestrant valbociclib 125 milligram per day as LHRH. So adenosumab, as I mentioned, was added while she was inpatient, plus calcium and vitamin D. In 2 weeks, I brought her to the clinic. She was tolerating the treatment very well. Her CBC was within normal range, as well as the liver function test. Her performance status started to improve. Her performance at that time was 1, and she was pain-free, the good thing. So CT test and abdomen and pelvis in August 17 showed interval sclerosis of pre-existing extensive lytic bony lesions, and the abdomen and chest remained free. If we can compare the one in the left side, is the old one, and the one in the right side, the new one, there was some improvement in the form of more sclerosis of the bony lesion in the spine. So we agreed to continue since the patient was tolerating, and there was benefit from the hormonal therapy, and there was no major toxicity. So the same dose was not reduced, and we kept on fulvestrant and RH. As I said, her performance continued to improve. Her performance was 1. She used to come walking to the clinic without any support, without any help. The first 6 months, I used to see her monthly. And then I noticed in the first 3 months, her CBC never dropped, and the liver function test was normal, but the patient herself was very keen to come on monthly basis, although she was from outside Riyadh, but she asked me to come on monthly basis for the first period. Then after 6 months, I started to see her every other month, and during all these periods, she was doing great, and all her imaging were showing improvement in the bony lesion, and there was no evidence of distant metastasis, a part of the bone disease. So this is a bone scan in April 2018. We can see the multiple areas in the right side. If you look at the bone scan in 2017, there was improvement in the skull lesion, in the spine lesion, in the iliac bone lesion. So she had sclerosis of most of her bone disease. Some of the bony lesions remained the same. There was no change, but the good thing that there were no new bony lesions. So in January 2019, she developed generalized convulsion at home. She brought by the family. They were so worried and anxious about development of new brain metastasis, since they saw the same scenario like 3 years ago. So on examination, she was alert and conscious when she reached the ER. There was no evidence of neurological deficit, and there was no other complaint like weakness or numbness or loss of sensation. The only thing that she developed convulsions, and she was out of it when she reached the ER. Nerve CNS examination, normal cranial nerve exam, power, tones, and sensation were intact all over the body, and the heart performance was 3. So she underwent complete body imaging, including CT scan of the chest, abdomen, pelvis, and MRI of the brain. The CTs showed no evidence of disease, but the brain MRI in January 19 showed progression of the same lesion. So tumor, the new lesion was 2 by almost 1 centimeter. So this was recurrence of the, there was a residual disease, as I mentioned, and changes, post-radiation changes at the surgical bed. But obviously here there was real progression of the disease. So there's a mass now in the new MRI. So the one at the left side is the CT, the brain MRI in April 17, and the one in the left is the MRI, the latest MRI, when she presented with new seizure and CNS symptoms. So she had been admitted, started on dexamethasone. After the MRI, we called neurology. The dose of Keppra had been increased to 1,500 milligram BID, and we asked our neurosurgeon to reassess her for possible resection. And at the same time, we called our colleague, the radiation oncology, for evaluation. Her general condition started to improve gradually immediately after the start of IV dexamethasone. So she had PET CT scan, and again, no evidence of disease outside the brain. The only thing which was positive in the PET CT scan is the brain lesion. In the CT scan, there was evidence of gallbladder cholecystitis, and we were asked to do abdominal ultrasound. The ultrasound showed small stone, and there was evidence, as I mentioned, of cholecystitis, but the liver function was normal. There was no obstruction. As seen by GI surgeon, they just advised IV antibiotic and conservative management, and they planned to do surgery like 3 months from that event. So we brought the case to breast tumor board. We used to discuss our cases on weekly basis. So everybody agreed that this patient is having her disease is controlled outside the body, outside the brain. No evidence of new lesions in the chest or in the abdomen. The only thing that is growing is a brain lesion. So the neurosurgery team, they said they don't need to intervene again and do another surgery. The radiation oncology team agreed to do SRS for that lesion. So we agreed to continue on the same treatment since the patient is having controlled disease outside, as I mentioned. All the bone lesions stayed the same with even more sclerosis, and CA15-3 was almost stable. So she received SRS to the single brain lesion in March 2019. And this is her CT scan and brain CT scan, sorry, immediately after SRS. So comparing that MRI to the one before treatment, there was less enhancement at the surgical bed, and the mass was a little bit smaller. MRI of the abdomen showed improvement in the cholecystitis, and the GI team just adjusted follow-up. So we did not change her treatment, and her performance went back to normal, or one immediately after completion of radiation, and with the tapering of the steroid dose, she was back to her normal function status. So the tumor board, everybody agreed to continue valvocyclic Fulvestrant and LHRH with the help of calcium, vitamin D, and the monthly denosumab. So this is in June 19, as I said, blood tests were normal, and this, as I mentioned, everything was stable according to the latest CT scan and bone scan. So, but at that time, she said, I'm tired coming from outside Riyadh on monthly basis. I asked her to come every other month, but she said, no, still, I can't do that. Can you just write for me a medical report so I can continue treatment there? To make sure that she's having the same medication as her area. And the son was like, yes, please do that, because she's not happy. Psychologically, she's not happy. So in August, I continue calling her son like every other month. She was fine according to him, but in September she developed some sort of depression. She started on treatment, but she opted to stop all her medication. November 2019, she developed lung and liver metastasis. she had very bad impairment of the liver function test, and she passed away in January 2020. Thank you.
Thank you very much, Dr. Nafisa, for this interesting and challenging case. So we will open the floor for discussion if there is any question. Let us see the Q&A if there is any question.
Can I have a question? Can I ask a question?
Yes, please, Mohammed.
Okay, so I don't treat a lot of breast cancer, but just a question: since this patient is failed twice in the brain, was the option of using other CDK4/6 that has some CNS activity considered?
Yeah, okay, thank you, Mohammed, for this question. Actually, if you notice, this data was in 2018, actually end of 2017. It was just before the evidence or the new data that came from ibimaciclib. Even these, you know that we are talking about one class of medication. There are three, but all of them are CDK4/6 inhibitors. So the data is very limited. We know that most of the patients who are having brain metastases, most of the time they are not included in the clinical trials. In the BALOMA-2 and BALOMA-3, they did include few patients of brain metastases, but all of them were having asymptomatic disease or treated disease. And after that, the incidence of disease progression was really very minimal. So what happened did not generate any recommendation or anything to endorse regarding the effect of CDK4/6 inhibitor on the brain metastasis. Then we had the data from ibimaciclib after that. It was data were very encouraging, but again, it was limited number of patients. And we know that the brain metastasis is many things affect that. Radiation, we don't know when the medication can cross the blood-brain barrier. So the data from ibimaciclib was showing a little bit improvement in BFS in patients who are having brain metastasis from breast cancer, but not from other cancers, because they included patients having colorectal cancer, lung cancer, but there was no significant improvement. Again, the number of patients was very small. So the data is limited. So we don't have anything to support moving from one CDK4 inhibitor to another one.
Okay, good. Yeah, Dr. Nafisa, I have one question also. As you mentioned, this patient started the second line in metastatic setting in 2017. And at that time, we did not have the PIK3 inhibitors like alpelisib. So
yes.
if in this case, if we have the medication at that time and the patient turned to be PIK3 mutant, do you will start her on alpelisib or you will go for the CDK4/6 inhibitor?
Thank you. I mean, it's a very tough question. Really, I don't know. But having this mutation, yes, I can go for that. But still, I'm having good data from CDK4 inhibitors. I think I'll be using that medication at that time and leave CDK4/6 inhibitor for the second line and third line, for example. I don't know. It's really difficult question, difficult to answer.
So any more questions? I don't see the A and the answer question. I need Q&A here. You be in the chat or where? The questions from the audience.
Okay, Nafisa, I have another question. You mentioned this patient, she was treated somewhere else and she received 5 years of tamoxifen. So looking backward to the details of the case, would you consider duration of 10 years of adjuvant endocrine therapy on this patient?
Yes, I do. Yes, I will consider this patient. And if she is in my hand now, I will think of it many times, and I will really recommend her to use that one, because at that time she was premenopause. So this is per se is a high risk factor. You saw her staging post neoadjuvant. She was T2, like N2, M0. So by all means, she's high risk patient by age and by disease and by staging. So N2 disease, tumor the grade was not high, but her age and her staging are encouraging me to label her as high risk patient and thinking of starting CDK4/6 in the adjuvant setting.
Yeah, thank you. I think I have one question here from Ahmed Osman. He said that his repeated biopsy from brain would be optimal to be sure about no changes in receptors.
So the first presentation, which she presented with brain metastasis for the first time, that the whole tumor had been excised, and it was confirmed that it was the same like the first biopsy, first disease, like ER positive, PR negative, and HER2 negative. So as a second recurrence, we did not do rebiopsy since it was almost the same area, no other new lesion, and expected to be the same pathology.
Okay, for Nafisa, I have a question also here. What about the role of chemotherapy in such a case in the metastatic setting, especially the second relapse, which I think occur after 1 year or less than 1 year from starting letrozole?
No, it's like more than 1 year, But if you notice, I mean, the relapse was in the brain. The relapse was mainly in the brain, and we are not sure of this medication, either chemo or CDK4 inhibitors. We're not sure which one can cross the brain barrier. We don't have strong data. Maybe after brain radiation, all of them can do that. We don't have a strong data. Plus, no evidence of organ crisis. So we know that this is a major indication, or the main indication of starting patient on chemotherapy when they have this pathology. Plus, her Ki-67 is very low. It was 5%. So I don't think there was a strong indication. There was no indication to start her on chemotherapy with this pathology.
Maybe
and in the absence relapse, of organ crisis.
Maybe in the last relapse when she's outside your
yes,
institution.
Yes, at that time, yes, with flare-up of disease and having very high liver function test, yes, this is a time to consider chemotherapy.
Okay.
I have one more question, Nafisa. So you mentioned in her course of disease, she developed depression. So is there, we know that the cancer itself is a cause of depression, but is there any association between the palbociclib and worsening of pre-existing depression or causing depression?
I'm not sure, Mohammed, about that. There's no association, but we know that there is some association between brain metastasis sometimes and having depression, the disease itself and depression. But medication-wise, I'm not sure of that, Mohammed. But I'm not aware of if there is any data saying that the CDK4 inhibitors can increase the incidence of depression among those patients.
There is, I think, this may be the last question before moving to the second case. And this is from Dr. Ahmed Raslan. I think you answered this. If there were visceral and brain metastasis, what kind of chemo would you choose? It means if there is visceral metastasis with the brain metastasis, do we use chemo or still you are going?
If there is visceral metastasis with crisis, I will go for chemo. If there is visceral metastasis without crisis, still hormonal therapy is a valid option. Which chemo we know that single agent do the same like double double agent of chemotherapy. And the most important thing here is to consider the performance status and the quality of life of the patient. Her performance is well, but we know that giving her two chemotherapy will not change the overall survival or PFS. So I might consider Taxotere single agent. I know that some people might think of giving carboplatin because they think it's more, people think carboplatin can go easily to the brain, especially after radiation, but in breast cancer, carbo as a single agent, I think would not be of great benefit. So if I will choose to go or I have to go for chemo, I will go for taxane single agent.
Okay.
If the liver function, for example, was normal.
Clear. Thank you very much, Dr. Nafisa, for your nice case.
Thank you.
And nice discussion. So I think we will
Thank
move
you
to
all.
the second case. Dr. Muhammad can take over from here.
Thank you, Dr. Amin. Thank you, Dr. Nafisa, for this interesting case. It's now my pleasure to Dr. Kanaan Shammari. He's a consultant GI oncologist and sarcoma, and he's
But your voice maybe is not clear.
Dr. Garmi, we lost you.
Maybe if you want to continue the introduction, Dr. Amin, until Dr. Muhammad sorts out his audio.
Okay, so it is my pleasure to introduce Dr. Kanaan Shammari. He's a consultant adult medical oncology, Department of Oncology at King Abdulaziz Medical City in National Guard. Dr. Kanaan main interest in sarcoma and GI malignancies and also hepatocellular carcinoma. Dr. Kanaan today, he will present a case, sarcoma case. Please, Dr. Kanaan, go ahead.
Thank you, Amin. Thank you for the introduction. And I also would like to thank the organizing committee for asking me to present a challenging oncology case. So before I start, I guess you are seeing my screen and you can hear me well?
Yes, very clear.
Right, thank you. So I was given the task to talk about a challenging oncology case in sarcoma. However, I actually spoke with the organizer, Dr. Ashwag, and I thank her for letting me present another rare tumor, which is not really a sarcoma. So before I actually start, I want to talk briefly about the objective of this meeting. I think Dr. Muhammad Al-Garni spoke in a bit of detail about this. So our aim here is to describe the approach of complex cases using newer technologies of diagnosis, therapy, and focusing mainly on multidisciplinary approaches. So one of my earlier cases, so this case was actually presented to me early of 2020, is a 22-year-old man who self-referred himself to our center in National Guard, Riyadh, as a case of metastatic, heavily pretreated hepatoblastoma. So basically, this young man came to me after he progressed at another local hospital in Riyadh. He unfortunately came with high expectations, and I'll speak briefly about this. He also went to the States for a second opinion and was told that his prognosis was going to be extremely poor. And his prognosis was very guarded, and he was expected to have only 3 months to live. So let me spend a bit of time talking about the past oncological history. So this young man initially presented at age 11, where he had abdominal trauma with abdominal bleeding, necessitating an urgent laparotomy and surgical resection of a liver mass. Histopathology revealed that this was a hepatoblastoma. So at that time, he was given chemotherapy for a year. After 2 years from finishing chemotherapy, he recurred approximately 2 years afterwards. So approximately his age was around 14 or 15. He went to the US, was given multi-agent chemotherapy until he achieved a near complete response. And this was followed by a liver transplant. 3 years following this, he was found to have reoccurred for the second time. And he referred himself to another local hospital here in Riyadh and was treated as suspected HCC/hepatoblastoma and was given transarterial chemoembolization as well as Nexavar. He unfortunately progressed after about 6 to 8 months. He then went to the second time to the US, to a large cancer center. He presented his case there for another opinion, and he was told that his prognosis was very guarded, and he was offered palliative gemcitabine and oxaliplatinum. He refused this therapy and presented himself to my clinic. On past medical history, he did have a history of major depressive disorders, and he was on antidepressants, and there was a remote history of a possible suicidal attempt during his time in the US. There was no other significant medical history. For his current medications, he was on everolimus as an anti-rejection medication. He was on 1 milligram once daily. He was also on opioids for pain, and he did not have any drug allergies. So initial challenges of this case are the following. This is a new patient with a long and complex history. He was treated at least 3 different facilities. If we consider the last US center where he went for an opinion, if we consider that, it will be 4 centers. He was heavily pretreated, so he was exposed to multiple chemotherapeutic agents in which he progressed. His expectations were very high, specifically coming to a new center. His family members were healthcare professionals and also had very high expectations. So my initial steps in management were the following. So I took a full detailed history, including his prior chemotherapeutic agents that were used. And we took this basically from his old reports from different hospitals. We obtained a baseline image. We took a sample of histopathology from the last resection that he had. We asked for it to be reviewed in our institution. And we carefully explained our role in National Guard Riyadh as a new center and as a medical oncology team to set the expectations at an appropriate level. So this was his baseline image. This was his first image when he approached me. This was February 2020. And as you can see, I hope you can see this clearly, he did have innumerable liver lesions. He also had a new ileal lesion with some lymphadenopathy. So with this so-called new small bowel lesion in a patient who had a transplant, he was on immunosuppressants with regional lymphadenopathy. We had to think about different types of pathology. And hence I actually asked for a biopsy of this lesion after I presented it in our tumor board. So biopsy of this revealed or confirmed that this was metastatic hepatoblastoma. So at this time, or the current level of this patient, was that he was a young man with extensive disease. Performance status was prior to treatment 1. He was heavily treated. He did have an extremely rare tumor with minimal, if no data in the adult population. So what would be the first thing that I would do? It would be to consult my expert colleagues. So why did we need to do this? So just going back a little bit, the way I want to approach this case presentation is we want to stop at certain points and talk about learning objectives. So the first thing here is that this young man presented to an adult oncologist. He was heavily pretreated in multiple centers before. His tumor was extremely rare in the adult population. We did not have any data supporting therapy in the adult population. There was very minimal, if no adult data. And in our medical oncology's GI group in my center, we did not really have much experience in treating adult hepatoblastoma. So I did consult some of my adult colleagues, and again, we did not have much experience. And hence, I actually approached some of our pediatric colleagues. I consulted 2 of them. We discussed all the prior therapies. We discussed the patient's current status. And we collectively decided to give him multi-agent chemotherapy. And this is basically since his disease was extensive and metastatic. Now, what we focused on is previous chemotherapies that this patient was exposed to. We actually noticed that there was one agent that this patient was not exposed to whatsoever prior, which was irinotecan. Now, this is when we examined all of his prior medical notes. Now, irinotecan on its own, we know that objective response rate in GI cancers is actually very modest. I found this publication, which talks about vincristine and irinotecan as an addition to standard therapy in patients with refractory high-risk hepatoblastoma. Now, this was a pediatric patient. So after consulting with my pediatric colleagues, we decided to start him on multi-agent chemotherapy. We gave him actually carboplatin etoposide, alternating with vincristine and irinotecan. I decided to give him 4 cycles followed by imaging. So I gave him almost 3 months of therapy, and I imaged him again. And as you can see, his liver actually became larger. He did have progressive disease in the liver by an increase in his liver lesions, as well as an increase in his ileal lesion. Now, just before imaging, he was showing some signs of possible clinical progression. His fatigue was worse. Now, I can't really blame fatigue only for clinical progression because I was giving him 4 different types of chemotherapeutic agents in a dose-dense fashion. So maybe it was chemo. However, his LDH and alpha-fetoprotein were also slowly trending up, and he did develop some mild ascites, maybe indicating some liver decompensation. So prior to us doing the imaging after 4 cycles, I actually discussed with one of our senior pathologists, and we decided to send his tumor for Foundation 1, for next generation sequencing. And this was done prior to radiological progression. So his Foundation 1 report showed him to have a mutation in CDKN2A/B gene and an alteration in CTNNB1 gene. Now, mutation in the above gene tells us that he may benefit from CDK4/6 inhibition. Absolutely no data in hepatoblastoma. And the same thing goes for the CTNNB1 alteration. No data in hepatoblastoma. So at the moment, after this progression, he did have radiological as well as clinical progression. His performance status was really borderline and becoming 3. I sat down with the patient and his family, and I explained to them that we currently have no evidence-based treatment approaches. And I offered him 2 options. The first option is that I refer him to our palliative team for symptomatic management approach. And my other approach was a trial of palbociclib. And I told him that we have no evidence in palbociclib in specifically hepatoblastoma cases, and that this was really going out of the box. However, the patient and his family have reported that they wanted everything to be done that has life-prolonging effects. So I started him on palbociclib, standard dose of breast cancer, 125 milligram daily for 3 weeks on and 1 week off. And this was basically based on the next generation sequencing data. He actually tolerated this therapy quite well. In terms of toxicities, he developed grade 1 neutropenia. I did not really stop his medication or even dose reduced him. He did have clinical improvement and biochemical improvement, which was a reduction in his alpha-fetoprotein. His first imaging study, now this is a close-up coronal, showed stable disease, basically. Now, in here, I just want to pause for a few minutes, and I want to talk about what we have been doing in National Guard Riyadh for the last probably 6-7 months. So we started an initiative where we have been conducting molecular tumor boards with foundation medicine experts, where a scientist or a molecular genomicist and a medical oncologist would join us after reviewing the foundation medicine report. We would then discuss molecular and oncogenic pathways that are associated in the Foundation 1 report with potential therapeutic targets. The medical oncologist with the FMI team would then suggest possible therapies based on the NGS data or molecular pathways. Then the primary oncologist, in this case myself, and attendees would have a chance to discuss therapies offered and other possible therapies with potential benefit. Then the MRP would have the final decision regarding patient therapy. So the suggestion from this team meeting, which was done later after I actually started him on palbociclib, was to give palbociclib CDK4/6 inhibition, and they also suggested mTOR inhibition. So this patient was on everolimus, if you remember, 1 milligram daily, so a low dose. Now, active doses, such as in breast cancer patients, are around 10 milligrams daily. So what I have, or actually, I'll talk about what I did to my patient later. Let me talk about next generation sequencing or comprehensive genomic profiling. So basically, it has established its way as almost becoming standard of care in certain diseases, such as non-small cell lung cancer. We are using it more and more often, and we have promoted using it in newer tumor types, such as cholangiocarcinoma, where we expect mutations to be present in more than 60% of advanced cases. Now, multidisciplinary teams are used in approaching such difficult cases. In this case, the Foundation Medicine Molecular Tumor Board, led by the National Guard team, or moderated by the National Guard team, we would combine molecular information, imaging, pathology, patient characteristics and information, and combine those and discuss these complex patients and come up with possible therapy approaches that may have clinical benefit. Now, multidisciplinary molecular tumor boards do benefit patients. They involve multiple specialists that range from oncologists, genomicists, molecular biologists, and pathologists, and also radiologists. The aim of these molecular tumor boards is to interpret complex genomic data and provide the best possible clinical decision. They do facilitate interpretation of complex molecular data. They would definitely promote assigning patients on precise therapies, so basically precision medicine or precision oncology approaches based on molecular changes or mutations. They would provide education, and I really like this part with the Foundation Medicine Molecular Tumor Board on molecular pathways, their findings and how they relate to treatment strategies. And they keep track of open clinical trials abroad or locally. So I think I spoke about this, which is the International FMI Molecular Tumor Board, where we discuss clinical cases with Foundation Medicine reports, get insights from experts, which are medical oncologists and clinical genomicists, and we'd come up with a consensus decision on the best possible therapy that can be provided to the patient. Now, I want to spend just a few more slides talking about other international centers with multidisciplinary molecular tumor boards. One of these molecular tumor boards was done at the Herbert Hermann Cancer Center. So this is a center in the US. And they basically have started around 2017, where they actually presented 54 cases. Now, all of these cases were quite advanced because they failed multiple lines of therapies. Oncologists would present these cases who have foundation medicine reports or comprehensive genomic profiling. Now, of these 54 cases, 81% of those presented had at least one actionable mutation. 12 of these 54 have received genomically matched treatment, and 13 of those 54 had options of therapy ready at progression. So they were presented a little bit earlier prior to progression. And I think probably this is the way to go. And 6 of those 12 patients that were given molecularly targeted therapies were alive after 1 year. So 50% chance of survival in this cohort after being presented with their molecular tumor board. Another molecular tumor board was done in France, so multiple centers. Now they have used an older next generation sequencing assay since they have been using it since 2014. And they actually created a regional molecular tumor board where they would discuss patients without FDA approved or European Medical Agency, EMA approved genomic alterations. They would discuss these patients, and their conclusion was that patients who have been discussed at these molecular tumor boards had a much higher chance of being put on molecularly targeted therapies and benefiting, or they had a higher chance of being put on clinical trials. Another large cancer center, so Moffitt's Cancer Center. So this is a large cancer center in Florida. They specialize in clinical trials. They actually established their molecular tumor board in 2014. They treated more than 1,400 patients, so a very large group. And this basically led to more patients being put on targeted therapy and more patients being exposed to clinical trials. Now, this is a leading phase 1 or early phase clinical trial center. And I'm pretty sure that having a molecular tumor board basically helped them in their early phase clinical trials, since they will be finding rare mutations that can be targeted by targeted therapies. And of course, many, many more benefits and many more centers. So back to our patients, I elected to increase his everolimus from the 1 milligram anti-rejection dose to 5 milligram, and I continue his palbociclib. Unfortunately, he developed grade 3 transaminitis. Now, we think that this may be therapy related. However, he was on opioids after progression, and he was on a significant number of pain meds as well as antidepressants and multiple medications. So I consulted our palliative team and our clinical pharmacist. We tried to look for drug-drug interactions. I, however, elected to reduce his everolimus to 1 milligram until he recovered. And then I slowly increased his everolimus to alternating 1 and 5 milligrams of everolimus, since we did not have a dose of 2.5 milligrams in our hospital. Another CT scan after 3 months showed him to have a further stable disease. After he fully recovered in terms of his transaminitis and his CBC, I re-increased his everolimus to 5 milligrams, and I kept his palbociclib as per standard therapy. He actually tolerated therapy extremely well. I noticed his alpha-fetoprotein to be decreasing. His performance status also improved. He did have some clinical improvement. His last CT of the chest, abdomen, pelvis, which was done late January of this year, showed him to have his first partial response. So it basically showed his innumerable liver lesions to have necrosed. A significant number of them have actually reduced in size and have had some necrosis. His tolerance to therapy was excellent. Performance status became 0, so he's completely asymptomatic. And he actually stopped his pain medications. So this led to the patient and myself being happy. Now, unfortunately, a month ago exactly, this patient was actually admitted with small bowel obstruction. A CT showed this to be caused by his ileal lesion. We admitted him under our care. He really did not improve with conservative management. So we spoke to our general surgeons who have elected to take him to OR and have resected his ileal lesion and have done primary anastomosis. This happened in late March of this year. Now, I held therapy during that time. Of course, he was kept on the 1 milligram of everolimus as anti-rejection. He is planning to see me next week to assess restarting therapy. Now, he was actually admitted a few days ago, unfortunately, again, with a left-sided knee effusion, which was so a single joint effusion. He did have significant pain. We actually aspirated this knee effusion, thinking that this could be septic arthritis. However, the culture was negative, and the cell count and chemistry of that showed it to be possibly inflammatory arthropathy. We have consulted our rheumatology team, and he's currently being worked up for the etiology of this left knee effusion. So in the end, this is my last slide. So what have we learned from this case? So this was a complex case, or at least I think so. I think I have learned from this that I need to consult appropriately. I have consulted my pediatric oncology colleagues, since we as adult oncologists are not really exposed to hepatoblastoma cases, and these cases are quite rare, and they present usually in the pediatric group. Now, next generation sequencing technologies are extremely useful in patients. There are different assays. We have a local assay that was done in our translational pathology lab in National Guard, which is led by Dr. Saeed al-Turki. So we do a limited NGS panel. However, the Foundation Medicine panel does have a wider array of genes. I think they do more than 300 genes, which is what I have sent for this patient. Now, molecular tumor boards and precision oncology or precision medicine approaches are probably the future, or where oncology therapy is actually going. As I have shown you, NGS does open up more targeted therapies that are not FDA approved and can benefit patients, as I have shown you in this young man who has actually lived almost more than a year now with a very bad aggressive disease and was heavily pretreated. Now, in the end, I would like to join you to join us in our monthly National Guard National Molecular Tumor Board, which is done in conjunction with Foundation Medicine Group. Now, I have to say that this is funded by Roche, which I thank for leading this and helping us connect with the International Foundation Medicine Group in the US, and doing this monthly molecular tumor board, which definitely has benefited our patients and patients in other centers in Saudi Arabia. So if you have a case that you'd like to present in our next upcoming monthly Foundation Medicine molecular tumor board, please email me at one of these 2 emails below. And by that, I thank you all for listening.
Thank you very much, Dr. Kanaan, for this nice presentation, as usual. Indeed, it's a very complex case. However, I think this patient, he received a high level of patient care. I concur with you in regard of consulting colleagues for unusual or rare cases. It's always helpful for the patient. Also, the doing NGS for this patient and open a new options for the patient that was helpful for him is also an indication of high level of care. So I think Kanaan did a great job with this patient. And and also important thing is the during presentation you approach the family very well, because this is one of the thing that we should address in our daily care. I also
before you continue, Mohammed, I just also want to thank you, Mohammed, for helping me lead this Foundation Medicine Molecular Tumor Board in our institution. So Mohammed is one of the co-directors of this initiative that we have been doing in National Guard.
Thank you, Kanaan. And I also encourage all the audience to join us. It's very educational, and I believe this is the language of the future for oncology. And soon we have to go deep in the molecular biology. So we received, Kanaan, one question from Dr. Ahmed Raslan. He's saying that the molecular tumor board is a good idea. However, it should be under the umbrella of clinical trial and consenting the patient about therapy. So what do you think about this?
So thank you, Ahmed. I agree with you. However, in our region, we don't have as many open clinical trials, specifically early phase trials, where they take rare molecular or rare mutations and offer them therapy based on these specific mutations. So we actually don't have many early phase trials open in our region, and hence we have to think outside the box and offer our patients the best possible therapies. Now, having an umbrella of a molecular tumor board, so we have developed this in National Guard even prior to joining our colleagues from the International Foundation Medicine. We have actually done this for about perhaps 2 years now, Mohammed. And this was led, initially started, 1 year, initially led by Mohammed, and I joined him later. And we have done these types of in-house or in-hospital and now perhaps national molecular tumor boards to help give us an umbrella and perhaps a better consensus decision to basically provide our patients with better therapies. More opinions are definitely better than one opinion, and more expert opinions are better than one expert opinion. And it also serves as an umbrella to A, help our patients, and B, to protect us, because we do have some form of an umbrella that will help us with regards to ordering rare therapies that are non-formulary, perhaps. Yes, so I think I hope this answers your question, Ahmed.
Dr. Amin, you have any question or?
No, there is no question to ask. This is
so I'm seeing. So
yeah,
I'm seeing. Yeah, a question by Ajit, and it's a very good question actually. If we find a mutation, how do we know that this is the driver mutation? So it's very difficult. I agree with you, Ajit. It's in fact extremely difficult. So one of the things that we actually look at when we discuss with our molecular pathologists is VAF, which is the allelic variant allelic fraction. So if the allelic fraction is high, now this does not really translate, or you shouldn't really take this as a general rule. However, it does help. If the allelic fraction of a specific mutation is high, then the likelihood that this may be a driver mutation is somewhat higher. Now, we also discuss our cases again with molecular genomicists, translational pathologists, and they help us in determining whether these types of mutations possibly could be driver mutations or not.
Okay. Thank you very much, Kanaan, for this nice case and nice discussion. I think Nafisa, she has something to say.
Yeah. Thank you, Kanaan. Very nice presentation.
Thank you.
I have no idea about the hepatoblastoma, but is transplant is an option if the disease is limited disease?
So this patient was actually offered the transplant. He was transplanted when he was 15. طبعا his disease currently is not limited, although because he had a terminal ileum metastatic deposit with regional lymphadenopathy. However, we did resect his terminal ileum when he presented with an obstruction, and we did remove a significant number of his lymph nodes. So currently he has only limited disease in his liver, But I wouldn't really promote transplanting this patient since he is having heavy disease burden in the liver. We always think about transplant when patients actually have small or limited disease burden.
Yes.
If you remember with HCC, they have the San Francisco and the Milan criteria, and it always talks about the limited disease burden. So 3 small tumors less than 3 centimeters or 1 tumor of less than 5 centimeters. It never really promotes transplanting patients with innumerable liver mets, because with heavy immunosuppression, after transplant, there's always a risk of reflare of these tumors.
Okay. Thank you.
So thank you very much, Kanaan.
So we will move to the last case, which is genetic cases, which will be presented by Dr. Mohammed Al-Barni. Dr. Mohammed Al-Barni is section head of cancer control and outreach program, and he's also a consultant medical oncologist and clinical cancer genetics at King Abdulaziz Medical City in National Riyadh. So, Dr. Al-Barni, please, the floor is yours for the genetic cases.
Okay. Thank you very much, Amin. So I don't think my cases are so complex like Nafis and Kanaan. The main aim of this
You're talking science, Mohammed.
So the main aim is just to have some learning points from about cancer genetics and what's happening in the clinic. So I'm starting with my first case. This is a 33-year-old female with no significant past medical or surgical history. She was diagnosed with luminal B breast cancer in, in 2019, and it was ER/PR strongly positive, HER2 negative, and Ki67 was high, 90% approximately. So she was treated with neoadjuvant chemotherapy in form of AC followed by docetaxel until February 2020. Then she had modified radical mastectomy on March of that year. The final pathology revealed T2N1A disease. Then she was referred to the radiation team, and she received the adjuvant radiation that was completed in July 2020. And she has been on tamoxifen with LHRH since March of 2020. Then she was referred to oncology genetic clinic for assessment. So basically, this is a young woman with breast cancer. I think she was 30 at the time of diagnosis, and now she is 33, and she was seen in our clinic. So what we do is we have a detailed assessment for the family history, including the family pedigree. In this patient, there was no family history of breast or ovarian cancer, no other cancer in the family. She has 9 siblings, all are healthy. So the driver for doing genetic testing in this patient is the young onset breast cancer, despite no past family history of any form of cancer. So this is the result of her genetic testing. It's a comprehensive gene panel that we send out. It's a commercial available gene panel. And it reveals that this patient has a pathogenic mutation in Brib-One gene. So this is the first case, a case of young onset breast cancer with no significant family history, and she has pathogenic mutation in Brib-One gene. So let's move to the second case, then we'll go back to both cases. This is again a woman in her 30s, but she was 28 when she was diagnosed with metastatic rectal cancer to the liver with significant large lesion in the liver, about 9 centimeters in October 2018. The tumor was RAS, PRAF wild type and proficient in mismatch repair. She was treated with Folfox and Banitumumab between November 2018 and April 2019. And I have to say, to give the credit for the treating oncologist for these cases. I was not the treating one, but we were involved as a part from the cancer genetic. So her first CT scan after the first courses of chemotherapy revealed almost complete resolution of the rectosigmoid mass, with significant improvement of her locoregional lymphadenopathy and metastatic liver lesion. It got smaller in size from 9 centimeter to 4 centimeter. She was discussed in the tumor board, given her impressive response to therapy. And since the tumor was mainly rectum, she was offered short course of radiation that was completed on April 2019. And she was offered segmental liver resection and low anterior resection on May 2019 with a stoma and with her initial surgery that was also revised and closed in January 2020 with no evidence of disease at that time. So she was on follow-up CT scan and it showed there is a growing left para-aortic lymph node that was treated with SBRT on May 2020, and the patient on follow-up since then with no evidence of recurrence. So we saw the patient in the genetic clinic, and we offer her the same gene panel that we do for all referred patient to cancer genetic clinic. And in this patient also, she has Brib-One gene mutation that causes frame shift, and it was classified by the lab as likely pathogenic mutation. I have to say for this patient also, she has no significant past medical history of colon cancer, breast cancer, or ovarian cancer. So basically we have two cases of young onset breast and colon cancer with no significant past medical history. So now we come to the role of genetic clinic. So it has been a general perception that the genetic testing is meant only for identifying cancer or identifying genetic mutation that predispose to certain type of malignancies and offer certain recommendation for prevention and surveillance, which is true, and this is major part of what we do. However, the cancer genetics is growing rapidly. We are not just using it for surveillance or prevention. It's in addition to the cancer risk assessment, it has a tool for prognosis and predictive. It helped to personalize our way of recommending prevention and screening for each individual cases. And this is also most important for those who develop cancer and carrying certain mutation. It has clear therapeutic implications. And for medical oncologists who are treating and using chemotherapy, the whole story of microsatellite instability came from Lynch syndrome. And now we can see in the clinical practice how this has been translated to an agonistic marker that can be used across all tumor. And there are many other examples. So it's not only about cancer risk assessment. So what is the Brib-One gene? So Brib-One gene is an abbreviation of BRCA interacting protein C-terminal helicase 1. It's one of the tumor suppressor gene, and most of hereditary cancer syndrome happen in the tumor suppressor gene. This Brib-One gene is interacting with another important gene, which is BRCA1, breast cancer gene 1, that's involved in repair of homologous recombination pathway. So it's a DNA repair mechanism sort of gene. It's tumor suppressor gene, and it has interaction with very important gene, which is BRCA1. So what does this mean for patients? So someone carrying pathogenic mutation. So when we are talking about mutation, we are talking about either heterozygous or homozygous mutation. So most of the mutation happen in heterozygous. So most individuals, they carry normal allele and abnormal allele. And this can predispose the patient to certain type of malignancies. However, if someone has pathogenic mutation in Brib-One gene in both allele or homozygous mutation, this will lead to Fanconi's anemia. So what is the cancer risk associated with Brib-One gene? So the most of the evidence that we know is for ovarian cancer. So those who's carrying Brib-One gene mutation, they have a cumulative risk of ovarian cancer that reach to 10%. They're contradicting data about the breast cancer. However, there's some data suggesting that those patients tend to develop breast cancer, especially triple negative breast cancer, which is not the case of our patient. And there is no really data to suggest association between colon cancer and Brib-One gene mutation. Another important concept when we look to the certain gene in the clinic, because this is what will help us and guide us during the discussion with the patient about whatever intervention we are going to offer, is what is the penetrance of this gene. So what we mean by penetrance, if someone carry a certain, carry a genetic mutation, what are the percentage of patients who carry this mutation that they are going to express a phenotype of cancer? So to make it easier, so if you look to a P53, it's considered one of the highest penetrance mutation because the patient is at very high risk of developing cancer. BRCA1 and BRCA2 and APC also the same. It's high penetrance mutation. Many individuals carry this mutation will develop cancer. What about Brib-One? It's not considered a high penetrance mutation. So it's a moderate risk. So this information, it's useful for us in the genetic clinic when we discuss with the patient, because you have very strong reason with the BRCA1 and BRCA2 to recommend salpingioophorectomy or mastectomy for certain patient. However, you might not have the strong indication to do this with someone with moderate risk allele. This brings us to another important point. In these two cases, the current, most of the guideline recommending certain clinical findings in the family history that promote genetic testing. But now we learn more and more that adhering only to guidelines or certain criteria to test for certain genetic syndrome is leading to missing some of the patient who's carrying this mutation. So now the school is moving toward more of universal testing. And what do we mean by universal testing is non-selected patient with certain type of cancer, you do the screening regardless of family history. So this is how things are moving. Example of this is the Lynch syndrome. So now you don't need to ask about family history when you have a colon cancer. You can screen the patient for MSI. And if they carry MSI mutation, you go through the pathway, whether you test for germline mutation or doing PRAF. There are a lot of details that is beyond the scope of this talk, but all patients with colon cancer should be screened for microsatellite instability. For patients with ovarian cancer, any woman with high-grade serous tumor, regardless of family history, we do universal testing. And this has shown that it's superior to restricting to the clinical guidelines. Now, this is what we do in patients with pancreatic cancer. The NCCN guidelines recommend screening for all comers with pancreatic cancer, either resected or in the metastatic setting. And this is what we are doing in our clinic. So this is how things are moving in the genetic clinic. So the indications is moving from just adhering to certain guidelines or criteria, although it's still important in certain type of syndromes, and moving toward universal testing. There is ongoing a study in breast cancer in the adjuvant setting, which is the Olympia study that is looking to the role of olaparib in patients with resected breast cancer. And if this study turned to be positive, this means that all patients with breast cancer, they have to be screened for BRCA gene mutation. So this means universal testing for BRCA gene mutation. The second important question when we decide whether to test the patient or not, how we can test the patient. So we have, if we use the two cases that I just presented as an example, if we test for BRCA gene only for that patient, which is the commonest gene mutation associated with breast cancer, we will miss the finding of Brib-One gene. And for the patient with colon cancer, if we just do the single genetic testing for Lynch syndrome or APC, we will miss that the patient has Brib-One gene mutation. So it's more and more advisable to go with panel testing, which has its pros and cons. So it's efficient, it's less expensive than doing each single gene testing. It increases comprehensiveness and increase your chance of detecting the mutation rate. However, sometimes the turnaround time takes a long time, and I think it's now weeks rather than months. It may be costly in certain situations. One of the downsides is that you are testing for gene that you don't want to test for. And sometimes, and it's very frequent, when you order panel, you will find the result of variant of uncertain significance. So this is how we interpret the result. We have pathogenic and likely pathogenic. This means the patient carry a clear pathogenic mutation that predispose him to certain cancer, and you can use this information to make a recommendation for your patient. VOS, which is variant of uncertain significance, there are certain change in the gene that we don't know, is it really disease-causing mutation or not? And for this type of VOS, it has to be interpreted in the context of the patient, and you don't really build a lot of risk reduction intervention based on VOS. If the patient doesn't have any pathogenic or likely not pathogenic, so most likely the patient does not have any genetic syndrome that predisposed to syndrome. So I think we already touched on that how we can use the result. It's to help the patient in terms of risk reduction and for therapeutic options. So what does NCCN recommend for a Brib-One gene? As I mentioned, there is limited data about how we can use this information in patients with breast cancer, and they cannot make a clear recommendation. For ovarian cancer, there is clear association with Brib-One gene mutation, and it's recommended to consider a risk reduction salpingo-oophorectomy between the age of 45 and 50. However, the association with other cancer is unknown. So we don't know what is the association with the Brib-One gene and colon cancer. So back to our first case, the patient with breast cancer and Brib-One gene mutation, how we can in the genetic clinic use this information and talk to the patient. So the first thing is what we have evidence for is the risk of ovarian cancer. So the patient was referred to Gyne-Onc for consideration of prophylactic PSO. However, we are not pushing hard at this stage to have the surgery done, since we know that it's a moderate risk allele, and the risk usually after the age of 40 to 50, and the patient still want to have more kids. So it's very reasonable to wait for some time before considering this intervention. Now, important questions that was discussed with the patient. What about prophylactic mastectomies? So again, there is no strong science beyond to offer contralateral mastectomy for this patient. However, if you take it into the context, this is a woman who developed breast cancer in her 30s, early 30s, and she has a clear pathogenic mutation that might be the reason for her cancer, and she's definitely at risk of developing second malignancy. So it's an optional, it's not a strong recommendation that we can make. And this is what we discussed with the patient. Since she is on tamoxifen, which hopefully will reduce her risk of recurrence of breast cancer further or a new primary breast cancer, we can wait for the mastectomies, and we can offer as an alternative intensive surveillance with mammogram and MRI in alternative schedule. And we advised her to bring family for genetic testing. So what about case number 2, the woman with rectal cancer at age of 28? Actually, if you look to the literature, there is no really significant data. However, there are reports of 2 cases that develop colon cancer, and they carry a pathogenic mutation in Brib-One gene. So in this study, our patient is the youngest so far, so she's only 28. The two patients here are 58 and 60. But the learning point in this case is all of these three cases, either the two cases that was reported and our patient, they received oxaliplatin and they have remarkable response, all of the patients. Now, for our patients, you might argue with the left-sided tumor that is RAS wild type. It's maybe just the response of anti-EGFR, which is true to some extent. However, you have a young patient that you would think the biology is bad, and usually their response to therapy is not good. And I think one of the driver of her response to the oxaliplatin-based chemotherapy is the mutation in Brib-One, which we know that it's a tumor suppressor gene that is associated with homologous recombination pathway. And we know those with homologous recombination pathway deficiency, they have a better response to platinum-based chemotherapy. So I would assume that it's a contributing factor to her response to therapy. As I mentioned, there is no clear association, so we cannot build a strong recommendation for surveillance for the patient. However, again, we have to reduce the risk of the patient from other cancer, like breast cancer. So we requested for her a baseline mammogram, and we will consider referring the patient for gyne-onc for prophylactic surgeries if she remains free of her rectal cancer. So just to summarize, the genetic cancer clinic or genetic counseling, it's required a multidisciplinary approach from molecular genetics. The genetic counselors need surgeon, you need the fertility clinic with you, we need the good radiologist, you need psychosocial supports and resources for the patient or the affected individuals. And remember that 10 to 15% of the cases is related to hereditary cancer syndrome. Always refer the patient to the genetic clinic because the counseling and the interpretation of the genetic test required certain details and expertise. And as I mentioned already, germline mutation has important role in individualized risk assessment and management option. And remember, it's a multidisciplinary care. And by this, I conclude my talk. Thank you very much.
Thank you very much, Dr. Mohammed, for these nice cases. So we will open for discussion. So I may start with one question. For those family members, if you ask them to come for screening, are they coming for this? And can we accommodate these numbers in our clinic to do the testing for the whole family?
Thank you. I mean, it's a very good question. So whenever we order a genetic testing and we find a pathogenic mutation, I think we are obligated to screen the families. However, this is depend on the patient if she want to disclose this information with the family or not. This is number one. So what we do in the clinic, because as you mentioned, the number is really significant, and the waiting time now for some family to book them to come to our clinic is 4 and 5 months. So what we do in the clinic, once we identify the mutation, we do Sanger sequencing or Sanger testing. So we test specifically for the mutation that we identify in the patient. And we open for the patient one visit to the lab, so they can do the genetic testing. If they tend to be positive for certain mutation, like the BRCA gene mutation, patient with FAP, we extend their eligibility because those patients really need specific follow-up and intensive surveillance. If the patient is not tested positive, so we discharge them from the clinic. And for the other mutation that we don't think the patient need to follow with us, we provide them with the medical reports and detailed recommendation. So what screening they should have, and they are following where they are eligible.
Okay, thank you. I have another question. If the patient refuses the intervention, especially in these two cases, for example, to do oophorectomy. If they refuse, is there another way to do screening for them, like radiological, periodic radiological, like CT or?
Yeah. So the issue with the ovarian cancer is there is no really good screening modality, and when it happens, it's present in advanced stage. This is the challenge. However, not all the patients agree on this. So as alternative, which is suboptimal, we might do transvaginal ultrasound and CA125 on annual basis. However, the sensitivity of this is not really high, but it's considered an alternative options if the patient opted not to have the surgery.
Okay. But in those cases, it is like only 10%.
Yeah, the risk. Yes. This is the risk is 10%, and this is the reason even why we are considering doing the oophorectomy at age of 45 to 50, which is later than the patient with BRCA1 or BRCA2, because as I just discussed, it's a moderate risk allele, and the risk of developing the cancer is 10% as a cumulative risk.
Okay, thank you. I will see if there is any question. Dr. Na'an, Dr. Nafisa, anyone have any questions?
Yes, I have a question. Great case, Mohammed, very educational. I have a question about some ethical dilemmas that you might face in your genetic clinic. If, for example, a patient gets or has a genetic disorder after you actually do your comprehensive genetic testing that has a major impact on their offspring or children, and the patient refuses to tell their children, how do you approach such cases, Mohammed? And have you actually been involved in such case?
So thank you, Kanaan. I think this challenges comes more to a patient with the pediatric, or they have metabolic disorder. The cancer genetic is somewhat different, because we are not talking about 100% the patient who carry mutation will express the cancer. It's just carrying a gene that predisposes them to certain malignancy. So I can tell from my experience with, let's say, more than 400 patients that we tested so far, I never found an issue with talking to the patient about their offsprings. Actually, some of them, we don't need to screen them before the age of 18. However, you find the family bring them at age of 9 and 10 and 11 years asking to do the test. I think the issue is with disclosing the information with the siblings and other first-degree relative. As you know, in our society, labeling certain family with certain mutation, it has a social ramification, and that has a lot of details. So if the patient opted not to disclose this with their first-degree relative or sibling, I think this is their right. But for their children, I never encounter any patient refusing to disclose or to bring the family for screening.
Excellent. Thank you.
Very nice cases. Mohammed, whom can we involve if we are facing a family with, like, for example, BRCA positive, and like we have 2-3 ladies at the early 30s having this BRCA positive mutations, and they refuse to do any further intervention? Are you the only one, or you can ask the help of some other services? Whom can you call? Who can help you in that?
I think one of the challenges with young patient is having the risk reduction surgery, because many of them, they are still single. Many of them they want to get kids. Some of them, they are married, but they still want to have more kids. So always it's important to involve the service that's going to do the surgery, because sometimes they have some uncertainty and they just need to sit with the one who's going to do the procedure, and they can be reassured and have an answer to their questions. So I always to suggest to the patient, even if they refuse the surgery, to sit with, for example, with the breast surgeon, sit with the plastic surgeon to see what are the options after mastectomies, for example. And after doing this, sometimes there is no rush to have the surgery. So we can re-emphasize this in multiple visits. Fortunately for breast, we can do some alternative like intensive surveillance. And with each visit, we try to re-emphasize on the role of prophylactic surgery.
Okay, I'm not seeing any more questions. If there is any more questions, so I will leave you the mic to Dr. Muhammad for the closing remarks.
Okay. Allah يعطيكم العافية. Thank you very much, Dr. Amin, for the moderation. Thank you, Dr. Kanaan, Dr. Nafisa, for the excellent cases and discussion. It was really refreshing and light meeting, and hopefully to see you all tomorrow with more interesting cases, and we'll be in the same time, inshallah. So see you tomorrow all.
Inshallah. Thank you.
Inshallah.
Thank you.
Thank you very much.
Muhammad and everyone. Have a good night.
يعطيكم العافية.